Hi, it's Dr. Abbas Ali, a cardiologist with 3 decades of educational experience. Today we're going to discuss the post-ROSC patient journey in patients who have undergone cardiac arrest. Initial phase 1 is immediate ROSC and triage. Is the etiology of the cardiac arrest a STEMI, in which case the patient needs to go to the cath lab directly. Once it's decided it's not STEMI, then we go to phase 2, where we cool the patient and manage him in the ICU. Then the phase 3, where we do neuroprognostication, survivorship. So the immediate thing to do in these patients is to get a 12-lead EKG. If there's STEMI, then STEMI should be activated. Patient should go directly to the cath lab. Following this, consider pan-CT imaging to assess etiology of the cardiac arrest and point-of-care ultrasound to look for etiologies such as tamponade. Then, if patient has STEMI or shock or severe ischemia or malignant ventricular arrhythmia suggesting underlying ischemia, emergent coronary angiography should be done. If the patient is stable or has NSTEMI, we should do delayed angiography. This is based on evidence. These are the various trials that assess this: Emerge, QUAC, Tomahawk, and Pearl trials, with a cumulative total patient count around 1,300, where they showed emergent versus delayed coronary angiography in these patients did not show any benefit. Actually, in the Tomahawk trial, there was a suggestion of harm for early coronary angiography. Once patient is in the ICU, we should do optimal blood pressure management, keep MAPS around 65, adequate oxygenation 90 to 98%, and ventilation. Proper temperature management with temperatures from 32 to 37.5 degrees. Prompt EEG monitoring and assess for non-convulsive seizures. Use standard anti-seizure medications for diagnosed seizures. Do not do routine prophylaxis. When you find patterns on EEG that need treatment, then appropriate therapeutic trials should be done for that. There is a 72-hour window when it is difficult to decide the outcome of the patient. Following this, you should do multimodal prognostication, consider use of biomarkers, and clinical signs and EEG. On clinical examination, if the pupillary light reflex is absent for more than 72 hours, if the corneal reflex is absent for more than 72 hours, these are both bad prognostic indicators. Also, role for serum biomarkers. Once a patient is found to be brain dead, then we should look into whether they're an organ transplant donor or not and go down that pathway. Overall, cardiac arrest is a difficult clinical problem. Time is of the essence. Thanks for watching. More to follow.